Hello, everyone. Good morning, good afternoon, good evening. Welcome to another Residency VMR. My name is Ethan from Taiwan and CP Solar's team member. Today we are delighted to welcome friends from University of Wisconsin Hospital and Clinics today, which is also our beloved CP Solar team member, Ambish, work as an intern right now. So maybe Ambish and Dr. Mazams, do you want to introduce yourself and tell us how life in residency has been so far?
Ambish, you can start.
Hey everyone, I'm Umbish. As a lot of you already know, today is a very special day for me because my program is presenting a case and my chief Mazen is here. I'm really excited to be here. And do you want to know a little bit about the program, or I can give the mic to Mazen to introduce himself?
Yeah, we'll do a Q&A session after the case, so maybe we can do that part. So maybe
Yeah.
Mazen, you want to introduce yourself?
All right. Good morning, everyone. I'm joining from Madison, Wisconsin. It's 11 in the morning now. My name is Mazen. I'm one of the 4 IM chiefs. I did my med school in Riyadh, the capital of Saudi Arabia, at Al Faisal University, before moving to Madison, Wisconsin for residency and stayed for another year as a chief resident. And a bittersweet feeling, probably leaving in few months for GI fellowship. I'll be moving to Cleveland, joining the Cleveland Clinic team. Thank you so much for having us. We're really happy to join and share our experience in our program, and I'm excited to present this interesting case. And thank you, Ambish, for connecting us with the CP Solver teams and for being an amazing resident at our program as well.
Thank you so much. Congratulations on matching the fellowship event. Yeah. So let's move on and introduce our case discussants. We have Dr. Manu as attending in our case discussion seat. And we have our two amazing CP Solver Academy member, Rahul and Ibrahim, discussing with her today. So maybe Manu, Ibrahim, and Rahul, do you want to introduce yourself?
Sure. Hi, my name is Mo. Thank you so much, Mason, for being here and bringing this case. So I'm a IMG from China, but I've been a hospitalist for a few years. I'm currently in Portland, Oregon. I've been very lucky to be part of the CP Solvers team, learning together with all the wonderful members we have here. So with that, I think I'll pass the mic to Ibrahim and Rahul.
Hello, everyone, and good morning to you all, or good afternoon, I should probably say. My name is Ibrahim. I am a medical student. I'm a Saudi Sudanese medical student. I'm originally based in Jeddah, Saudi Arabia, but I'm currently based in Cleveland. And I'm honestly very happy to be here today, just because I have to say this. So last year, same time, it was Umbish actually applying to residency, and I remember how everyone was like stressed out just because, it's like applying to the match, right? Um, but yeah, it's crazy how the world works, and it's crazy. Uh, yeah, that now Umbish is actually presenting a case during the same time. Some CPS members are also applying to this year's match. So yeah. And Rahul, I guess I'll pass the torch to you.
Hello, hi. Good morning, good evening, good afternoon. I'm Rahul. I'm a medical graduate from Hyderabad, India. And Mazen, welcome to the CPS, and thank you so much for being here and presenting the case. And thank you, Ambesh, for connecting the Mazen to the CPS. I'm very, very excited to learn from Mazen's case and very excited to discuss with Ibrahim and Dr. Mingyu. Thank you so much.
Very excited for the discussion. So we are already sharing the screen. So Mazen, take the mic, please.
All right. Thank you so much, and thank you again for having us. So maybe we can start with the chief complaint. So this is a 70-year-old guy with history of hypertension who's presenting with shortness of breath for 2 days.
Okay, so Mingyu, would you like to start on with the first aliquot?
Yeah, so did you say you want me to start, or would you or Rahul want to tackle
Yeah,
that?
please. No, please.
Yeah,
Take a
or
shot at
Rahul,
this.
do you want to? Okay, I'm happy to start. shortness of breath is a common chief complaint we encounter in this space. And I think Mazen even helped us more by providing the time course, which is 2 days. So that fits like the acute, not the hyperacute, but acute course. And it's happening in a 70-year-old male, which opens a lot of the common differential diagnosis we encounter in the space of shortness of breath. So, I mean, you can use your reflex thinking to think, like the most common ones on top, like shows up frequently are like heart failure exacerbation, COPD exacerbation, PE pneumonia. So those are very common. But I think if we want to be systemic, you like to there we can apply the framework that we often talk about, which is the dyspnea pyramid. Because we don't know if the patient has hypoxia yet. If the patient has hypoxia, then my focus will be more on the cardiopulmonary, which is like the bottom 2 layers of this pyramid. But for now, I would also think about the non-hypoxic causes switching. So I would go from the top, like if the patient has any acid-based problem, like metabolic acidosis, they could have a compensatory response by breathing very fast and shallow. Or if the patient has anything that causes respiratory alkalosis, and then blood, and the second layer is blood, like bad blood, or no blood, like anemia, that's another thing. And then cardiopulmonary, there's a lot, which I suspect is where that case might lead us to. But I'm going to pause here and pass the mic to Ibrahim and Rahul to see what do you think?
Yeah, Rahul, if you'd like to go, you can go ahead, my friend, and then I can go last.
Sure, Ibrahim. I mean, thank you, Dr. Mengyu, for laying down some common differentials when we're approaching the acute presentation of shortness of breath. And I really liked it. You differentiated the cardiopulmonary system along with anemia and any other systemic problem, like any hyperthyroid conditions. But when I see this patient on the bedside in the ER, I would really like to explore about his activities of daily living. I mean, I want to see whether this shortness of breath in this patient, is it limiting his activities of daily living? I mean, is he able to ambulate himself, go to the restroom, and is able to walk, and is able to eat, and such kind of that really tells me the severity of illness, and then I could able to cater my differentials based on the cardiopulmonary system. And when Mazen presented the case, the patient has a history of hypertension. I'm just curious, maybe if the patient is compliant to medications or non-compliant to medications, maybe that is causing any kind of hypertrophic. I mean, it's very early to speculate the information on the hypertrophic. The hypertrophic cardiomyopathy, present kind of shortness of breath. But these are the points I really want to know. And moreover, I really want to look for any other systemic illness, any presence of fever, like fever with presence of shortness of breath. That really makes me to think of pneumonia. Any presence of ongoing pleurisy type of chest pain with acute onset of shortness of breath makes me think of pulmonary embolism, or else any kind of orthopnea, any PND, any peripheral edema, that really makes me think of heart failure, any kind of palpitations, or any kind of other associated finger changes, any chylonychia, any mucosal changes, or any glossitis, stomatitis, makes me think of any kind of anemia. And yeah, those were my thoughts. But I feel that as more information comes in, and maybe we can able to narrow our differentials. Yeah, Ibrahim, what do you think?
Yeah, honestly, great thoughts, both Mengyu and Rahul. And I'm not sure if I can add much to what has already been said. I guess just circling back to the shortness of breath or dyspnea pyramid, which we're often taught in CPR. So I'll actually post the link in the chat for everyone who wants to take a look at this. And I think I love the dyspnea pyramid, not just because it outlines how you approach dyspnea, but also because even if you're unfamiliar with the whole schema, you're able to walk your way through it. The reason being is that it's largely built on a structural foundation. So if you think about shortness of breath, you typically think about the chest. And if you think about the chest, then you can think anatomically what exactly exists in the chest. And the main two organs that exist there are basically the lungs as well as the heart itself. And when you approach shortness of breath, when it comes to either of these two organs, once again, you can think about it in anatomical fashion. And so when you think about the lungs, we mainly think about the lung parenchyma. So anything that can exist in the lung parenchyma or in the airways itself can manifest in shortness of breath. So things like COPD or asthma could definitely present in such a manner. And then you can also think about all the vessels that surround the lung itself, especially in a patient with a history of hypertension. I think the biggest thing that we would want to rule out here is something that is emergent and of vascular etiology. So something like a PE would probably arise to the surface once you think about this patient. And then you can also think about other supportive structure that exists surrounding the lung itself. And so you can have the pleura itself. So if you have an effusion, or if you have the diaphragm that exists below the lung itself, if you have a weakness in the diaphragm, usually I would expect this in a patient who recently underwent surgery or had a trauma, but I don't hear that in this patient. And then second, if you approach the lung and you think that this patient does not have a pulmonary signature, you can think about the cardiac causes that can manifest in dyspnea. Once again, if you think about it in a structural manner, you have the heart muscle, you have the electrical activity that goes through the heart muscle, and then you also have the valves. So whatever would impact either of these structures would result in shortness of breath. And then, of course, you have the vessels. So ACS, acute congestive heart failure, something like aortic stenosis, all of these can result in shortness of breath. And finally, you can think about all the other causes that can also manifest in shortness of breath. So things like anemia, panic attack, metabolic acidosis, all of these can also result in shortness of breath. So I think next step for me would mostly be to take a full detailed medical history from this patient to try to find a signature towards either of these categories, and then take it on from there. So Rahul and Mingyu, unless you have any other thoughts to add, I think we can move on to the next other part.
Sounds good. I look forward to Mason's case in more details.
Absolutely. Great discussion. Thank you, Dr. Mingus. Thank you, Raul and Ibrahim as well. So 4 days ago, this patient started having increased mental fogginess and felt unsteady on his feet. He started also having generalized fatigue and shortness of breath, fevers and chills. So he went to another hospital and went to the ED. But because of the long waiting time, he left AMA. Fortunately, before leaving, they did get some labs and they called him saying, your D-dimer is high, so you need to come back to the hospital for further evaluation.
Yeah, that's interesting. Rahul, Abraham, what do you think?
Yeah, so honestly, so it seems that this patient had a prior history. So I'm just trying to look into the HPI once again. So it seems that this patient had a history of a viral infection that eventually got him into the ED where he left, and they had labs that included a high D-dimer. I have to ask though. So I know that D-dimer is like often sent out for almost every patient, but Mazen, do you know why they send for a D-dimer in a patient with a signature of an infection?
I think given his shortness of breath and older age, a lot of the time in the ED, they send for D-dimer to decide whether they need to pursue like PE workup with a CTP study or not. Although, like, we know the sensitivity for D-dimer, like the specificity for D-dimer, the sensitivity side specificity is not great.
Exactly. So this is what I'm actually getting into. So I feel like, so for those who may have now read about this before, when it comes to D-dimer, it's actually largely non-specific, and this is why you often don't send it for every patient in the hospital, because then if you send it and it comes back as very high, just like this patient, you have to kind of do like an extensive evaluation just to figure out why this patient has a high D-dimer. And there's a lot of physiological as well as pathological causes that can result in a high D-dimer. So physiological things can include things like if a patient is elderly, this can result in a high D-dimer. If the patient is pregnant, this can result in a high D-dimer. If a patient had recent physical exercise, this can also result in a high D-dimer. And then, of course, just like Mazen mentioned, there are the pathological causes that can result in D-dimer. So anything that can result in occlusive disease of the vessels. So venous thromboembolism, disseminated intravascular coagulation, things like cardiovascular diseases, all of these can result in a high D dimer. And so honestly, for me now, just looking at this patient's high D dimer, I don't think I would make anything out of it yet. The most I would make about this patient is the fact that they had a history of a fever or of an infectious signature. And so when you think about infection and then shortness of breath, the first thing that comes into mind is cardiac etiologies or cardiac manifestations post-infection. So things like pericarditis, myocarditis, all of these can happen after an infectious etiology. So Mengyo and Rahul, I'd love to hear your thoughts as well.
Yeah, go for it, Rahul.
Yeah, I really loved your, the differentials of the D dimer given the non-specificity of the given condition. But I really want to, when he came to the right now, I don't have the much information to really comment on the D dimer. But when the patient got admitted to the ER 4 days ago, I really want to look at the vitals here. Specifically because the patient has, the patient is saying that he is having some mental fogginess and feeling unsteady. And I really don't know. I really want to explore more about that history because he's saying with a subjective history, but I really want to know maybe he's having any kind of dizziness or any kind of fluctuating confusion or any other neurological findings. And moreover, the emphasis of the vital signs, or I feel it's very important. Maybe the patient he got any EKG, or for example, if the patient has an evidence of hypotension and with evidence of tachycardia, in that situation, the pretest probability for pulmonary embolism is very high. And I feel that really gives us some clue. And moreover, most of let's say if I have a headache and fever, I also feel like a kind of fatigue. But I really want to explore more into the generalized fatigue because the patient has a history of hypertension, and I really don't want to prematurely disclose as pulmonary embolism, but I really want to deep dive what is fatigue and is it really impairing his any kind of activities. And I feel based on the points, and I'll try to make some kind of reflex assessment and to think of any kind of pulmonary embolism. Or you mentioned that the presence of fever with chills, with ongoing shortness of breath, is there something going on with infected endocarditis? But if the fever and in that situation, when the patient came to the ER again, I really want to look for the fever patterns. And that really helps me in narrowing my differentials. So those are my thoughts. What do you think, Bengo?
Yeah, I love what you discussed. I think practically speaking, when I have a lot of patients like this, like elderly patient who came in with some confusion, some generalized weakness, I would interpret those for now as like a generalized weakness and confusion, which could be in the setting of infection or sepsis. And later on, the fever and chills, which basically suggests that there's an infection. My default thinking is like it might be a pneumonia, so I would get an X-ray to confirm, get labs to see if there's leukocytosis, and empirically treat it and anticipate improvement to further support. And how do I take the elevated D dimer? So as you all mentioned, it can be in the setting of inflammation, like an infection. So it may not be specific. However, I would be curious to learn the height of this D dimer, because as we know, there's like age-adjusted D dimer, which means if it's mildly elevated within the cutoff of the age, we might just say, it's part of the inflammation. Versus if it's really, really high, then my concern for thromboembolism process would be high. And I would, even if the X-ray shows signs of pneumonia, I might still get a CTA to confirm. But often, if it's not that high, then often in the ER, like people would just be empirically treated. And I also like knowing the patient's baseline would be helpful. If the patient have some baseline cognitive dysfunction, often they tend to develop delirium or confusion in the setting of an acute illness like an infection. So yeah, those are my thoughts for now.
Thank you so much. Great thoughts on dissecting the multiple complaints here, including the fatigue, the weakness, the D dimer, the elevation, the fever, and putting it in the right context for the patient age and comorbidities. I'm going to go through the review of system, try answering the questions you were wondering about, and maybe discuss the medications the patient is on, allergies, family history, social history, and then we can pause again. So at baseline, this patient is pretty functional, able to perform all his daily activities with no issues. So this was a change from his baseline. He doesn't have any chest pain. He doesn't have any palpitations that he is aware of. He said that his weakness is mainly just feeling tired and fatigue, and maybe he's having myalgias or muscle pain. He also endorses some headache and foggy mentation, as I mentioned. For his shortness of breath, it was only pronounced when he was walking his dog, but otherwise at rest it's not that bad. But it looks like it's been progressing more over the past few days. But he doesn't have any shortness of breath at sleep. He doesn't wake up in the middle of the night gasping for air. He doesn't have any shortness of breath laying flat. No recent sick contact that he's aware of. For his past medical history, he has history of hypertension and dyslipidemia. He's on hydrochlorothiazide, amlodipine, and lisinopril. He doesn't have any documented allergies, and he doesn't have any relevant family history. For his social history, he lives with his wife in Beloit, Wisconsin. He denies any tobacco use. He would only have 1 drink of alcohol per week, and he denies any illicit drug use. One of his main hobbies is hunting, and he just came back from a hunting trip 4 days ago. I guess I'll pause here.
Yeah, what an interesting information. Like, especially in the end, you mentioned about the hunting. I'm curious, Rahul and Ibrahim, what thoughts you were triggered by this additional information, this aliquot?
Yeah, so honestly, yeah, I feel like everything was like going very smoothly until the hunting was mentioned by the end of this article. So just I guess going through the review of system, um, so the fact that this patient had a normal baseline daily activity of function makes me think very much less that this patient had a prior congestive heart failure that hadn't been diagnosed. I'm just trying to think of this case as if you think of approaching a patient in a hospital. Oftentimes, even though this patient had like a history of an infectious etiology a couple of days ago, and it seems that their symptoms have started ever since, a lot of patients, when they present in a hospital, it's not necessary that these connections are vitally true. Sometimes you can have a patient that has had these problems for a long period of time, but it's only because they had this recent infection that they're now noticing their shortness of breath, which made them come to the hospital. And so just the fact that this patient had a normal baseline makes me think very much less that this patient had a prior congestive heart failure. The fact that this patient does not have chest pain, palpitations, no orthopnea also makes me very much less concerned about a congestive heart failure or something like a PE manifesting in this patient. And then I guess the past medical history, we've already known that this patient was a diagnosed case of hypertension and dyslipidemia. So not much from that. The hydrochlorothiazide, the amlodipine, and the lisinopril and ACE inhibitor also do not raise any concerns for me just because they're common medications, and it doesn't seem like this can typically be. So I'm going to assume that the hypertension has been a chronic issue, and so these are not new medications. So I'm not concerned about a drug reaction manifesting in this patient. The fact that they had no recent contact is also reassuring to me, just because if they had a recent sec contact and it wasn't something typical of a viral infection, then I'd be very much concerned that this patient may have had some kind of an atypical infection growing into them. And so I feel like I've discussed a lot of this article, so I'm gonna leave the rest for you, Rahul and Mengu. If you can take it on.
I loved your thoughts on, in catering all kind of the symptoms, but I really want to understand more about, in order to make the progress here, because the patient is completely fine. I mean, 4 days ago, 6 days back, 1 week back, and all of a sudden he's complaining of the kind of shortness of breath, which is of exertional variety. And in this situation, I really want, and with associated fevers and chills for 4 days, I want to think of any external etiology maybe causing this kind of symptoms rather than, as you mentioned, because the patient is stable, fine, nothing, not having anything, the probability of congestive heart failure is very less likely. And even the patient is, I thought maybe it's related to COPD, but the patient is not is a not smoker and is 78. It could be appropriate in a lung pathology. Maybe I was wondering, is there any possibility of any ILD pattern like interstitial lung disease or any kind of idiopathic pulmonary fibrosis? But I feel it does not cause this kind of acute symptomatology, and those will be having a lot of chronic and subacute to chronic presentation. And the hunting history is really, is intriguing here. To be honest with you, I really don't know what all the bugs really causes this kind of manifestations. And moreover, the patient has a history of fevers with chills and myalgias, a typical of viral prodrome manifestations. But I really want to keep an eye on the myalgias. And is a kind of myalgias, is it causing generalized fatigue, or is there any kind of not a usual viruses or any kind of bacterial etiology? I forgot the names, like any kind of tularemia and any kind of cattle. And I'm just curious to know about his occupational history. What does he do? And maybe I can get some clues from there. And I really get all the inputs from the ID team to really understand. Maybe I'll put up the up to date and see what all the organisms responsible, whenever he goes to hunting and those kind of things. And that really helps me in making the progress. And again, coming back, connecting the dot to the D dimer, right now I don't have any strong evidence to support the elevated D dimer, but I feel any kind of any vitals, any EKG would really helps me in narrowing my differentials, I guess. So those are my thoughts. What do you think, Dr. Mingyu?
Yeah, your thoughts are amazing. I don't know if I have too much to add, but I agree with like I think I love how you considered his his baseline, and then whether this could represent an exacerbation of a previous problem, which we don't get the signature here, but then layer on the fact that he has inflammation in the chest, and in the chest, and then also layer on the potential exposure related infections. So yeah, I think first I was a little struck by the the patient's normal baseline, but then coming in with kind of pretty significant impact on his mental status and weakness, and his general strength. So I feel like I wonder if that provides some clue to the nature of this infection, but also then further confirming, I think it's in a rather acute course rather than something acute on chronic, because we know, like, even when somebody presents acutely, it could be that they have a lung inflicting process and then just manifest as acutely. So here, I think, again, thinking about inflammation in the lung, it can affect many structures, but then given that we think it's more acute, I think that automatically makes like autoimmune or malignancy process lower on the differential. So we really focus on infection, which I think we have to rule out and consider now. And I think in someone who's healthy, like they don't have like a lot of risk factors for like aspiration or, live in a crowded environment or things like that. So I think that hunting history really provides it's something we have to look into. I think one way to dig more is like what kind of animal he was exposed to, because different animals you might get different but like classically we know like deer, or rabbit associated with for instance, tularemia, as you mentioned, Rahul, which is also something that came to my mind, because I was trying to remember among all the infections, which one has more prominence in the lung among all the like zoonotic infections. I think the short list I have that I learned from my prior VMRs are like hantavirus, rickettsia, lepto, tularemia, and yeah. Also, like I think just broaden a little bit. I think common things are still common, like common causes of pneumonia, like strep and strep pneumonia, but or Haemophilus. But I think this hunting exposure just broaden our differential. I think what would be really helpful is to see the labs, especially the CBC, to see if there's any signature of like a tick-borne or a doxycycline deficient state, because that will affect our antibiotic choice. Because if we see that, then yeah, I think then other bacteria like that's in my mind are like Legionella or fungal infections, because when you hunt, you have exposure to the soil, so a lot of the fungal infections. Or also when you hunt, you could have exposure to the ticks, bugs, also tick-borne illness, spirochetes, and yeah. So I think I'll pause here, and I'll see if Abraham or Rahul, you have additional thoughts. It's kind of fun to bounce ideas with you.
Yeah, honestly, thank you. I think you mentioned every single zoonotic infection out there. But yeah, honestly, with this patient and the fact that they had a history of hunting, just like you mentioned, I feel like it's very important to know the context of the hunting itself. So was it just like regular hunting, or did this patient end up actually hunting some kind of animal and ended up like eating the meat? And how exactly was it cooked? Because just all of these things can result in different zoonotic infections, and knowing the history surrounding the hunting itself can be very important. But I don't have much to add to what you've already mentioned. The fact that this patient went to hunting makes me think mostly of tick-borne infections versus tularemia, just like you mentioned. And something I do remember from my step studying is that in Wisconsin, you can also have blastomyces. So that's also important to consider, I think. But I wouldn't jump into either of these zoonotic organisms until I have a CBC and see if there's a signature of a leukopenia, for example, or a thrombocytopenia that could clue me into something like anaplasmosis, or any other signature that can clue me to other zoonotic organism in this patient. So not much to add. Thank you, Mango, I guess.
That's wonderful. Thank you, Abraham. Back to you, Mazen.
Yeah, absolutely. Great discussion. I loved how like this is the common thing to think about in Wisconsin when someone is out in the woods hunting, thinking about like endemic fungal mycosis, thinking like blasto, histo, very common in Wisconsin for sure. Thinking about tick-borne illness, also very common in Wisconsin, especially in the summer season. And then not forgetting the common presentations and common chief complaints like a typical pneumonia, Legionella, strep pneumonia, as Dr. Mingyu was mentioning as well. So thank you, great discussion. So to answer your questions, he didn't specify the hunting experience that he had. We didn't necessarily ask about it. We asked about animal exposure. Looks like originally he lived on a farm, but he hasn't had a typical like long exposure to cattle or farm animals since 1970. So we can move on and maybe talk about his exam and then pause again. For his vitals, so his blood pressure was 110/80. For his pulse, it was 113. For his respiratory rate, it was 32. And he was satting 90% on 2 liters of oxygen. And his temperature was 38.5. Overall, he was awake and alert. He was slightly fatigued in appearance, maybe appeared to be in mild distress. For his HENT exam, he had no conjunctival injection. He didn't have any like evidence of jaundice on sclera. His mucous membranes were like moist. For his neck exam, he didn't have an elevated JVD, and his neck exam was supple. For his cardiac exam, he was tachycardic, and maybe the tachycardia was irregular. It was very difficult to appreciate on auscultation, but maybe intermittently irregular, with a normal S2, S1, and no murmurs, rubs, or gallops. And then for his lung exam, there was a coarse lung sounds bilaterally with increased work of breathing as seen in the respiratory rate. And then his abdominal exam was pretty much unremarkable. It was soft, non-tender, with active bowel sounds, no evidence of hepatosplenomegaly. And then for neuro exam, he was alert oriented ×3, maybe intermittently confused, but still oriented to self, place, and situation. And no like gross focal deficit that we were able to appreciate. And then ending with his skin exam, he had a petechial rash in his left flank, left lower flank that he was not aware of.
So I guess just before we go on to tackling this aliquot, Mazen, I wanted to ask you, do you know how many more aliquots you have?
Should be 2 more. I think I'm
Two
gonna
more?
stop.
Okay.
So maybe I'll stop after the initial labs and then give you imaging and then final diagnosis.
That's good. So, Rahul, would you like to go first this time?
Yeah, sure, Ibrahim. Thank you. And thank you so much, Mazen, for giving the rich physical exam and the vitals. I mean, fortunately, his blood pressure is okay. 110/80. But despite having the normal blood pressure, he's having tachycardia, which could be suggested by the ongoing hypothermia. And he's saturating it on 90% and 2 liters oxygen. And there is increased work of breathing on exam. And I really want to anticipate what the pulmonary complication is going to be like. And he's going to suddenly crash, maybe needs any kind of NIV or any high flow or any kind of ICU intubation, because conditions like uh, um, you know I forgot the name, but uh, yeah, but some conditions like Weil's disease really causes this kind of manifestations where the presence of there'll be any accumulation of all the kind of pus. I'm really want to curious. I'm just curious to know whether is there any in this patient is there any because of given the forced lung findings. Maybe I'm going to anticipate some kind of infiltrates on chest X-ray, but I'm wondering maybe is there any presence of any pus kind of accumulation within the alveolus really causing this kind of manifestations. And apart from that, and looking at the petechial rash over the on left flank pain, I really want to know. It's very unusual. Basically, it's usually usually covered area, but I'm really curious what is causing this kind of petechial rash. And only the focal petechial rash is suggestive of any kind of external etiology, like in a tick-borne, as Ibrahim mentioned. And is there any correlation between the tick-borne with the ongoing pulmonary compromise? So those are my initial thoughts. And yeah, what do you think, Ibrahim?
Yeah, honestly. So I guess just trying to go over this aliquot. So the physical examination that we've heard from Mazen about this patient is that this appears to be a patient who's who has an infectious signature, but they're not necessarily septic. So their blood pressure is okay. They seem to be vitally stable, apart from the high temperature that they have. And the fact that they have tachycardia, and that was intermittently irregular, does not make me think of something specifically just because this patient has an infection. And I would assume that their body is just being hyperaroused due to that infection, which really makes me worried about this patient is the fact that they had this petechial rash. And the fact that they're only noticing it now means that we don't know how it started. So when it comes to tick-borne infections, the major association I have with rashes would be something like Rocky Mountain spotted fever or something like ehrlichiosis. However, we do know that when it comes to Rocky Mountain spotted fever, is that it usually starts peripherally, and then it typically, as it goes on in time, it typically starts to progress into a petechial rash that spreads more centrally. However, this happens usually in patients who have signs of a severe disease. But I would definitely keep that on the top of my differential. The fact that they did not notice the rash that it existed before that makes me think less of Rocky Mountain spotted fever, because if a patient had some kind of peripheral rash, you would think that they would typically be aware of it. Something else that I also associate with a petechial rash is ehrlichiosis. And when it comes to ehrlichiosis, I know that the rash itself can be either maculopapular rash or petechial rash. And typically it doesn't involve the palms and the soles of the patient. The thing that would really make me think of ehrlichiosis if this patient had a CBC with typical signature of ehrlichiosis. And so this would be something like leukopenia and thrombocytopenia. And the way I remember this is that ehrlichiosis tends to have a similar CBC signature to anaplasmosis. And then also, speaking of anaplasmosis, it can also present with a rash, but I do know that that is very rare. But just because this patient is a case that is being presented on CPS VMR, I also wouldn't rule out just yet. I guess for the main things that I would think in this patient is that I would, just because someone had already mentioned that in the chat as well, is that the CBC would go a very long way, because once you have the CBC and once you're able to see a signature, so something like leukopenia, thrombocytopenia, you can think about anaplasmosis or ehrlichiosis. If you have something like hemolysis and thrombocytopenia, you can think about babesiosis. If you have thrombocytopenia, and for example, on BMP, you had hyponatremia, you can think about Rocky Mountain spotted fever. So I think the laboratory testing would be the major takeaway for this patient. But Mingyu, I'd love to hear your thoughts as well.
Yeah, I'm so impressed by your discussions. I totally agree. I was even impressed by how you're able to differentiate these different doxycycline deficient state, where like using the clues on labs and exam. So I think where my minds went to was at first I think technically you can say this patient has sepsis because there's like tachycardia and fever, even though unfortunately the blood pressure is okay. But because with that, my one thought is that I want to make sure it's not a systemic bacterial infection like endocarditis or something that led to this particular rash. And I agree that rash seems to give us some clue and makes me worry. Also, going back a little bit, I think when you see a particular rash, remember like we want to see if it's palpable or not, because if it's not palpable, then you think about like bleeding disorders, like platelet issues or INR issues, which sometimes we can see in these type of infections. So I'd be curious to know that and see the platelet level or the coagulation panel. If it's palpable, then you think about like like microthrombosis, like inflammation in the vasculature, inflammation in the vasculature, like vasculitis or in certain infections, especially those certain tick-borne illness could mimic vasculitis, like some of the things you mentioned, like especially those rickettsial organisms. And I think dengue is another disease, like those viral hemorrhagic are like things on my list that could cause this. Although, I sometimes need to revisit the illness scripts that I learned over the years to kind of help me narrow down more. Yeah, I wonder, like at this point, I think let's see what the lab shows. I think as you all mentioned, it will help us make a lot of progress.
All right. Well, thank you so much. I guess for the sake of the time, I'm just gonna give you the labs and the imaging, and then maybe we can pause before like revealing the final diagnosis. Answering Dr. Mingyu's question, it was a palpable rash. So starting with hemoglobin of 11.5. White count was 4.9 with lymphopenia. Platelets were 88. Hematocrit was 35. MCV was 82. Sodium was 144. Potassium was 3.9. And then creatinine was 1.4. BUNF 22. And then glucose of 121. Then you have chloride of 117. Bicarb of 21. Then I also have a lactate, which was 1.2. A trope, which was 3.4. Downtrended to 2.6 on a repeat after 2 hours. CRP was 21. And ESR was 83. LDH was 514. Then AST was 122. ALT was 73. Then alkaline phosphatase was 140. Bilirubin was 1.0. And then we had an EKG, which showed a sinus rhythm with frequent premature ventricular complexes and the pattern of bigeminy.
Yeah, honestly,
And then
thank you, I guess.
do you
Yeah,
want me
do
to
you
complete
have
the images and then pause?
yeah, I guess if you're planning to do that, yeah.
Yeah, I guess the chest X-ray was unremarkable, and they did end up getting a CTP study given that high D-dimer. I feel like sometimes you're committed to it. If you're ordering a D-dimer, you have to think about the CTP that you're going to order after, which showed only mild pulmonary edema, but no PE.
So is that the end of it?
Yep.
Okay.
Maybe I can
Thank
reveal
you.
the diagnosis after this discussion as well.
Okay, sounds good.
Uh,
Thank you, Mazen. Yeah, so honestly, when I look at the CBC for this patient, I mostly see that this patient have a leukocyte count that seems to be trending more towards leukopenia, but I wouldn't call that just yet. The fact that they also have lymphopenia makes me worried that they might, in fact, be trending towards further leukopenia. But then when I look at the hemoglobin, it's mild anemia, so that doesn't seem to be super specific. But then when I come across the platelets being 88, I think this is what goes the furthest in here. Just because this patient has thrombocytopenia and we were initially talking about tick-borne infections, I know that tick-borne infections can result mostly in thrombocytopenia. So it's just further, I guess, evidence that this patient might, in fact, be presenting with a tick-borne infection. The rest of their workup does not make me very much worried, and it seems to go hand in hand with an infectious etiology. The thing, I guess, that makes me that provides further clue for this patient is the fact that they seem to have this derangement in their transaminases. So their AST is elevated at 122 and their ALT is elevated at 73. And both of these, honestly, I don't know, maybe Rahul and Mengyu, you could teach me more about this, but I am not sure if there is any tick-borne infection that can manifest with transaminitis other than anaplasmosis. And the fact that this patient seems to have the petechial rash, the leukopenia, the thrombocytopenia, all hand in hand make me go with anaplasmosis. That being said, I think ehrlichiosis, just because like ehrlichiosis and anaplasmosis, I mostly think about them in like a single category. So I wouldn't say just yet that ehrlichiosis cannot present with transaminitis. So those would be the two major takeaways that I am getting from hearing this patient's lab. But Mingyu and Rahul, love to hear your thoughts as well.
Yeah, thank you, Ibrahim, for sharing your thoughts on the labs. I completely agree with you. But when I look at this picture, Mazen, I have one question. Sorry, two questions. Do you have the baseline hemoglobin for this patient and baseline creatinine for this guy?
Baseline creatinine is 0.9, baseline hemoglobin is 14.
14. Thank you so much. So now we understood based on the baseline, there's an elevated creatinine. And given with moist mucous membrane, that really makes like think of any less likely of pre-renal or any kind of any intrinsic renal etiology. And moreover, looking at the pattern of elevated ESR, CRP with raised LDH with transaminitis, and thinking raise the creatinine with a new onset anemia, I would say, but give it, I really want to label this guy as a normocytic picture because MCV is normal with evidence of 3-point drop in hemoglobin and with a given thrombocytopenia. I really am, and answering your question, Ibrahim, apart from, as far as I remember, apart from anaplasmosis and ehrlichiosis, even Orientia Sisugamoshi would also cause us an elevated transaminitis, I guess. but based on the LDH elevation, I really don't know whether it's because of the any increased hemolysis. I feel maybe getting a reticulocyte count, looking at the marrow response would be my next step, and also looking for the peripheral blood smear, looking for any schistocytes or any kind of maybe looking adding any GIMSA and any kind of stains to look for any kind of organisms on the smear would be my next step. And other than that, the troponin of 3.4 to 2.6, it's downtrending, but I feel it's less likely of any kind of massive myocyte damage. Maybe it could result from the increase of increase of myocardial oxygen demand given the tachypnea and tachycardia. So those are my thoughts right now. But maybe I get a ready count and also looking for any other ordering the infectious panel, as you mentioned, anaplasmosis and anaplasma ehrlichiosis, or if possible, getting an Oriental chemistry antibodies. And yeah, so those are my thoughts. Yeah, what do you think, Mingyu?
Yeah, I think your thoughts are awesome. I think I agree with you with a lot of the things you said. Like, first, I think I when I see the CBC with the thrombocytopenia, maybe borderline leukopenia, and then especially also the hepatitis, AST/ALT elevation, I think that really fits a rickettsial or a tick-borne illness. And then also I kind of remember like with the particular rash, or especially the palpable purpura, like you really think about rickettsial infection. I think that's where my mind went into. And then although I also wonder, like with the AST more than ALT, should we check a CK just to make sure there's like not a muscle injury, because like certain infection could have a propensity to involve like muscle or cough. I think that's leptospirosis though. I think that's a little different, because for that you will see like more leukocytosis kind of neutrophilia kind of picture. So maybe not. And then I was also surprised by the lack of chest X-ray or CT abnormalities, but I think that maybe make it less likely like a lung centered infections that as we mentioned earlier. So maybe the infection, maybe the hypoxia or the shortness of breath was secondary to this like a systemic infection, maybe with some pulmonary edema, rather than like a localized lung infection. I think in the end, where I was thinking is, first I think with the LDH, I want to make sure there's not a hemolysis process going with the hemoglobin thrombocytopenia. I want to make sure it's not a hemolytic anemia going on, because that will also shift our differential. And then, HLH is another like differential, like that will cross my mind in the setting of LFT elevation and cytopenias. So I may check the ferritin. But I think for now, I'm really focusing on the rickettsial infection. But I think my knowledge gap is where, like, among all these rickettsial infections, like which one would have like there are subtleties of their presentation is where I need to read more kind of to differentiate those. So I might like treat as with like a doxycycline, assuming there's a doxycycline deficient state, and send some serologists based on like a local. So I would be in consulting our ID colleagues to learn like what are local rickettsial infections or other infections we should be considering. But I love your thoughts, and thank you so much for bouncing the ideas around. I'm curious to learn from Mason.
Yeah, thank you so much. Great discussion. I feel like I learned a lot myself about how to approach this and how to think about it. And you guys were always on the right track. So answering your questions, this patient had a haptoglobin, which was within normal limit. CK was within normal limit. We did send a peripheral blood smear, which showed intracytoplasmic aggregates within the neutrophils, consistent with anaplasma. Tick-borne panel was sent, and the anaplasma PCR came back positive. We also sent the endemic fungi workup, the histoblasto, given the like prevalence in Wisconsin, and this patient was in a hunting trip, came back negative. Strep pneumo was negative, Legionella was negative. ID were consulted and cards were consulted about this new bigeminy in the EKG, and they both agreed that this is consistent with anaplasmosis myocarditis. It's a rare manifestation of anaplasmosis, and ID were thinking that this mental fogginess and intermittent confusion might be also because of a presumed aseptic meningitis from anaplasmosis. So this patient was diagnosed with, was treated with doxycycline for 21 days and ended up having full recovery. And when seen by cards in clinic a few weeks later, he was in normal sinus rhythm and the bigeminy was gone. So great job, very nice discussion. A lot of good learning points for me, starting with from the dyspnea pyramid, going to the piece of information about the hunting trip and thinking about the differentials, thinking through like the CBC differential and physical exam findings. So thank you so much for walking us through your thoughts. I think this was a great discussion.
Thank you so much, Mason. And so blown away by your discussion, Ibrahim Rahul you essentially nailed the diagnosis. So I am very, very impressed. And I feel like Ibrahim, you had some wisdom to share with us before the case ended. Were you going to say something? Or
Yeah, I actually, yeah, so thank you, actually, thank you, and Rahul, for helping me throughout this case, I guess. I wouldn't have done it without all of you all. And thank you to everyone in the chat. Not sure if you guys were following up the chat, but there are some great thoughts mentioned as well throughout the case. And Mazen, thank you for taking care of this patient very well. I guess I just had a question about this. So I would assume that like the serology most likely did not come on the first day back. And so was this patient like initially started on doxycycline? How do you approach patients when thinking about tick-borne infections in Wisconsin? Do you just start them on doxycycline? Or do you just start them on empirically on something more broad spectrum, or what exactly is the
Absolutely,
approach?
absolutely. I think this is a great question and a very good way to end the discussion with the take-home approach. I think the way I think about tick-borne illness, I think about a four-step approach. So starting with, could this be a tick-borne illness? Is there any tick exposure? Is there any travel history? Was this patient on a hunting trip? Do we have any family members with similar symptoms? And what can also happen, and typically in the ICU setting, do we have sepsis without a definite source of infection? Like we have an infection, someone is really sick, we don't have a good explanation for any like typical bacterial, viral, or fungal infection. This is when we start thinking about tick-borne illness. And then thinking about second step, do we have the clinical symptoms and lab workup? Do they have fever, flu-like symptoms like myalgia, fatigue, shortness of breath? Do they have anemia? Do they have thrombocytopenia? And do they have leukopenia, and more particularly lymphopenia, and then transaminitis or elevated LFTs, which can manifest in all the tick-borne illnesses, whether that's Lyme, Rocky Mountain fever, ehrlichiosis, anaplasmosis, all can present with elevated LFTs. And then the third question I ask myself, and this is the question that's going to change your management, could this be babesiosis? Why is this an important question? Because all the tick-borne illnesses are treated with doxycycline except for babesia. So am I seeing any signs of hemolytic anemia, as Dr. Mingyu was alluding to? Do I see a decreased haptoglobin? Is the indirect bilirubin high? Do I see any parasites within the erythrocytes? And why is that? Because if it was a tick-borne illness because of babesiosis, then the treatment will be atovaquone and azithromycin, versus any other tick-borne illnesses, it will be doxycycline. So in general, we have a very low threshold to start doxycycline, given a very low harm. Doxycycline does not have a lot of like side effects. Early treatment can change the outcome really in the clinical course really quickly, and patients improve within like next day sometimes, like really quickly if you give them doxycycline. So in general, if we're suspecting any tick-borne illness, we do send the serology and the PCR. Usually the PCR is more sensitive, but we do start empiric therapy with doxycycline as soon as possible, keeping in mind the concept of whether this is babesiosis or not, because doxy is not going to cover babesiosis.
Okay, so just to make sure I get this right, so you're saying basically in a patient who comes in with a signature of a tick-borne infection, you mostly try to rule out first if this is babesiosis by looking for any hemolytic signature, and if the patient doesn't have a hemolytic signature, you start them empirically on doxycycline, right?
Absolutely, absolutely.
Okay, sounds good. Thank you for sharing that with us.
Absolutely.
well, I'm learning so much from you. Thank you for this brilliant case and presentation and the teaching.
Well, thank you so much, and thank you for having me. I'm happy to take any questions about our program. I know we're over time. Sorry for taking so much time, but happy to answer any questions about our program, about IM residency, about matching in the US. As an IMG myself, I went through this journey, and I know how stressful it can be, and how hard you guys work every day to reach your goals. So I really I would be really happy to help anyone and answer any questions.
Yeah, thank you so much, Mazen, for the great case. And I absolutely love your teachings, very practical approach to tick-borne-illness at the end, and great discussion, Ibrahim, Rahul, and Mangu. So now we're going into the Q&A sessions. So people, if anyone has questions regarding the residency that you want Ambush and Mazen to answer, please put it in the chat. And also, Ambush, tell me that we have another resident from Wisconsin, Dr. Ahmed Lazmin, also joining. So welcome. So Ibrahim, Rahul, do you have any questions? Or maybe I can start.
So I guess I just wanted to hear from Ambush or Mazen about your experience so far at the University of Wisconsin, and then I guess we could have questions about.
I can
Ambush, you can
start
go ahead.
because my experience is pretty brief. Mazen has lived in Madison for 3 years, and over that now he's the chief here. So my experience so far has been amazing. I feel really lucky that I came here and I did my rotations here, so I already knew where I was getting it, where I was going. The program is very nice. Everybody in general is very sweet here. There's a lot of learning. It's an academic setup, so there's a lot of learning, and you can see there's some textbook cases that we only read in books. Things like anaplasma, blasto, things that I had just read in books. I got to see them here. So there's a very good mix of cases. So far, my experience has been great, and I would totally recommend anyone from anywhere in the world to end up in UW.
Thank you, Ambush. Yeah, I had a great experience as well. The year they accepted me as a resident at UW was the first year they start taking IMGs. So it was a new experience for them accepting IMGs for the first time. And since then, they've been accepting IMGs on a yearly basis. The program is very supportive. Everyone's super nice. What I really like about our program is how we tailor the training based on your career goals and interests. So my residency experience is so different than my other co-chiefs experience. It's basically based on my career interests. So I was very interested in medical education. So I joined the medical education track, the TEACH pathway, learned more about how to conduct a medical education research project, how to approach a struggling learner, how to give a chalk talk, how to focus on clinical reasoning, but also got to work on one of the projects that I really love to work on is building a new orientation curriculum for international medical graduates when they join the residency in the US. And Ambish was one among the first learners in this program. So we tried to build a new curriculum to bridge this gap between like transitioning from a med school in your home country, and we understand how is it difficult to leave your family, leave your friends, your live culture, and move across the world to come in and get good training. So this is not easy, and being an intern year is not easy as well. So this extra support is needed. IMGs, they account for like 45% of IM residents across the US. This is a clearly described gap in med literature, and I was happy to be part of this initiative and start this new curriculum, and we're planning to implement it again for the second year this year. We mainly focus on building mentorship and networking, closing the communication skills gap, peer-to-peer mentorship, talking about clinical documentation, how to present in rounds, how to organize your day-to-day tasks. Coming from a different training background this can be really challenging at the beginning or at the start of the residency.
Thank you so much. So, Sini, I see you have a question in the chat. Do you want to read your question out loud?
Yes, sure. I just wanted to ask, what is it like living in Wisconsin, and what is work-life balance like in the program?
Absolutely. So living in Wisconsin means living with snow for 6 months. No, I'm just joking. It snows a lot for sure. It can be really cold. Coming from Saudi, that was like a cultural shock for me, but everyone's super nice. Madison is a very safe city. Madison is rated the second best city to live in the US in 2022. Everyone's super nice. A lot of different food options within the city. The program is very supportive. Our work hours are very reasonable. We average 55 hours per week, which is very reasonable. We have X plus Y plus Z system, which means you will be on an inpatient rotation for a max of 4 weeks, followed by an elective, followed by 2 weeks of a clinic block. So when you're on the elective or clinic block, you have protected weekends. We don't have any 24-hour calls. The max hours we have is 18, and that's for seniors. Interns are almost never left alone without a senior in residency. So you always have support from your senior or from your attending and the rest of the team to help you grow. We understand that this is a training program. No one is expecting you here to come and impress everyone. You are here to learn and grow. And that's why it's a training program.
So much.
Yeah.
But I see Eugenie has a question in the chat. I'm not sure if you're able to unmute and read your question.
Thank you, Ron. So what qualities make a resident successful in your program? That's my first question. And then what kind of research or scholarly opportunities are available for the residents?
Yeah, I think when I'm thinking about qualities that make someone successful, of course, everyone's going to say being like professionalism, making sure you're taking care of your patient, working hard. But what really stands out is having a unique story, having special interest. We have different tracks. We have health equity track. We have medical education track. We have opportunities for basic research, for clinical research, for transitional research. So having a specific interest within one of the areas is always going to make you stand out, and is gonna and the program is gonna support you for these unique opportunities. Answering your second question, what kind of research or scholarly opportunities are available for residents? So we have a research APD or associate program director. So every single intern or a first-year resident will meet with our research APD and within the first 3 months and talk about what research projects or goals do they have for the upcoming 3 years in their training. We do have a lot of faculty that work on clinical research. We do also have some faculty work on basic research. We do have secured funding, at least $2,000 per year for residents to travel abroad and travel within the state and present on national meetings. Last year, we had a record number of presentations. We had 55 residents present on different national meetings within our residency program. And the nice thing is the program is going to pay for it, pay for your hotel, pay for your registration, pay for food there as well. So it's a good experience in terms of growth for you and to be able to present and share your research findings, but also have some fun and explore other cities within the US as well. Those are the main thoughts I have. Of course, there are research opportunities within medical education and med projects as well. For example, last year I was given my interest in medical education. I applied for a medical education grant, and my program paid for me to participate in the Harvard Macy course for future clinician educators, where I got to learn more about how to grow as a clinician educator, but also how to implement my project, the IMG project, in a scholarly manner. Talked about 7 steps to develop a successful curriculum, how to start with a need assessment and survey learners, very important concepts in medical education. This is my experience based on my biased interest. Of course, if someone else has different interest, the program is fully supportive for any research projects for sure.
Thank you. I think that's very informative. So because of time's sake, maybe I can ask one final questions for Mazen, Ambish, and Dr. Ahmed Lazmin. So maybe you can share what is your favorite part about your residency program?
Maybe we can start with Lazim. We didn't give him a chance to talk. Lazim, are you with us?
Yeah, I'm here. Hi,
You want to
everyone.
introduce yourself?
Yeah, of course. I'm also an intern just like Umbish. So I did my med school abroad as well. I'm an IMG. I did my med school at Cornell in Qatar before moving here. So have much less experience than Mazen, obviously, but so far I love it here. So with regard to the question of um, what is my favorite part about UW-Madison in general so far, I think the most welcoming thing has been the people here. I can't stress it enough. I feel like in all my rotations so far, I've never felt unsupported. I've always had seniors, attendings, and even nursing staff. Everyone has been like very approachable, and by no means did I feel left out, like coming halfway across the world and settling into a new place. So I think that's been the most key thing in making intern year bearable so far.
Ambush, do you want to go next? Thank you, Lazim.
Yeah. Thank you, Lazim, for being here and sharing your thoughts. I think I agree with Lazim. My favorite part has been that I'm in a very, very well supported environment. I'm coming from Pakistan, and this was going to be a new home for me, and it truly feels like home. And I'm not just saying that; it actually feels that way. I go into work, and I do what I love doing. I practice medicine, and I'm surrounded by these very smart people who are always willing to teach, always willing to answer questions, and I've never felt stupid. And I've stopped judging myself. Every question is a good question here, and and somebody will always be present to support you and teach you. And our seniors are great. There's so many levels of teaching and so many levels of supervision, but then there's also autonomy that is given to us to come up with our own assessments and plan. And I love sharing that, and then testing it out and seeing if the attending and the senior agrees with me. So it's a very fun environment for me. And the other thing is I guess that's what I love about being here. And the program listens to you if you have any. We have our town halls where we can bring our issues to the program and we can share them. And something that I really like is the approachability. So our program director, Dr. Andy Coyle, everybody literally loves him. And when I started the residency, everybody was like, "Oh, we love Andy, we love Andy." And for me, it was a new concept because where I'm from, we go by the last name. And Andy likes to be called Andy. So, he's that approachable that I can just walk up to him and be like, "Hey, Andy, how are you? This is what I have today." So I like that, it's a very chill environment, I would say.
Wow, it's going to be difficult to answer the question now after you guys. I was going to say people, I was going to say how supportive the program is. You already mentioned all of these. So thank you both for sharing your thoughts. I'm going to add another thing that I really like about our program is our Friday didactic curriculum, or our curriculum in general. It doesn't only focus on helping the trainees to grow as physicians, but also as leaders. We have so many workshops and opportunities within the program that will help you grow as a person and as a leader. For interns, we have microaggression workshops, we have mock code workshops, we have central line workshops, we have acute situations workshops. For seniors, we have workshops with how to deal with rapids and code blues. We have workshops with how to teach for interns at the end of intern year to learn how to teach their residents. We have professional development days for interns at the end of the year that helps them with the transition phase, because being a senior resident is a different skill than being an intern. So many different opportunities and curricular sessions that help you grow as a physician in terms of like communication skills, dealing with patients, teamwork. We have an interprofessional training workshop where we have a workshop with physical therapists, occupational therapists, speech therapists, workshop with the ICU nursing. So you have to learn about how to work with a full team, and this is gonna help you become a better physician and help you grow a lot as well.
Thank you so much. I feel like it's such a great program and provides such great training, and the vibes and people there are just so amazing with a lot of supporting. Yeah, so if there is no any questions, I just want to thank you so much for the great case. And thank you, Ambush, for bringing your amazing residency over here. Hope to see you next time. Yeah. So I will end the session here and see you all in future VMR.
Thank you so
Bye.
much for having us.